thanks so much, Donna, for giving
You're
your
welcome.
time and to share your experience with the Community Wealth Building Gang in Wigan. We're going to have a bit of a conversation this morning about the work that the Northern Care Alliance have been doing, and hopefully get into some of the questions that have arisen from this work in Wigan, and kind of mine your learning and wisdom from that work that you've been doing to inspire us on the rest of the day as a Wigan gang. So an introduction to Donna before we get started. Donna's Director of Social Value Creation at the Northern Care Alliance NHS Group. The group employs 18,500 people and brings together health and social care services across Roxbury, Oldham and Salford. The group aspires to be an anchor institution that uses its power in a deliberate and purposeful way to support the economic development of place. Its anchor mission, which Donna has been leading since October 19, is to maximise its influence on the underlying cause of ill health, poverty. So Donna, that is pretty powerful as a clear mission and an approach. So can you tell us a bit about how a big NHS organisation has come to recognise that mission to address and tackle poverty is so core to your operations as a group?
So I think I'll answer it in two ways. I think the first is the Northern Care Alliance came into being as a group of services. So we are place-based, as you said, in terms of covering Salford, Bury, Rochdale, Oldham, and they're very different places. So in terms of, we have a group structure that supports, but we have a place-based leadership forum. So in each of our four localities, there is a care organisation who are the leadership team. And really, it's part of our next step of the development of integration. So Salford was, and Rochdale were both very early integrators between health and social care. And therefore, the next step, if you like, of integration is to look at the underlying causes of health. And I guess I'm always struck by the evidence that says, if you look at, health and well-being on an individual level, 10 to 15% of that is driven by what an acute NHS provider does, and 40% of it is driven by the social and economics of that individual in terms of employment, housing, income, sense of purpose. So if we really want to use we've got more power than just the brilliant work of caring for the sick. We actually can step into that 40% space and think about who we employ and how we commission our purchase our goods and services against that underlying mission. So it's both in terms of the next development of the strategy of integration and place-based leadership, but it's also, if we're in the field of health, we've got other things other than just pills and procedures that we can do that can impact on people's health. So there's a kind of moral argument and there's a business argument. That, so I can't win on your heart, then I'll go for your head in terms of the business argument. So that's kind of where we came to that.
Brilliant. And so what's it look like in practice? What did you get? Because we often there's this wonderful phrase that gets talked about in Wigan, that in the excitement of that realization that you've just described, you sort of think, well, okay, but how do I get started? And what was the first step to translating that vision into some change on the ground?
So I think having a board sign up was pretty critical. So we took the 2019 Health Foundation report and localised that for the Northern Care Alliance and took that into the board. And the equation I always come back to is I talk about narrative plus data plus action equals change. So the narrative, so let's talk about employment, because it's easier if we kind of focus on. So we've got five pillars, which pretty much mirror what you've written about in terms of CLES and other organisations. But so if we take people, so the narrative for people was, we need to move away from recruitment is a competition for a job to how can we use our employment power to tackle the underlying causes of ill health, which is poverty. So we've kind of thought about our mission around that. So in terms of by 2025, we want 60% of our workforce to be local. So from the communities of Bury, Rochdale, Salford and Oldham. We want to have 1,000 NHS career ambassadors, of which we're already at over 700. So that's landed really well with staff. So we know that, young children make gender decisions by the time they're 6 or 7. by the time you're 11, if you've not met the person or got a role model who works with that industry, the likelihood of you going into it gets narrower. So we kind of know that we need to work with our local communities around thinking around health as a profession, health and social care as a profession. And we've also looked at the data of our workforce. So we have about 750 level entry jobs. And so if we were to create 1,000 pre-employment opportunities, and that they are purposeful by looking at our data in terms of where do people live, the protected characteristics from people, how do we work to create those place-based pre-employment learning pipelines, and then that then becomes how we feed our workforce rather than sticking out a job advert. Because taking somebody on, a 12, 14-week pre-employment tour-based plus perhaps 6 weeks work experience, that's going to give us a better indication of a job readiness than a 20-minute interview. In all of our pre-employment opportunities, particularly those with partners, we put in our DBS up front, we do mandatory training, we do value-based recruitment. So you're getting a colleague who's already been inducted into the organisation and you've been part of that learning opportunity. So I think that's kind of how we're breaking down the big numbers and landing it. So against that 1,000 last calendar year, despite COVID, which it's still around and it's still a challenge, we've got 420 starts, and they are different. So some of them are NCA wide. So for example, Kickstart, we really took opportunity of Kickstarts, so they're across the NCA. We brought our FE colleges together to deliver T levels. We've got 80 T levels, and then we've got some really small community-based pre-employment opportunities. So there's one in Oldham that we ran from a faith-based organisation, so from a local mosque, within Coldhurst, which is the community that the hospital's based in. So did some really localised around people. Last week I spent a fantastic day with Women of Wings and Little Hulton Big Local, which are two real grassroots community-based organisations, just talking to them about what are the barriers to employment, and from that we're going to design a pre-employment programme directly with those. So it's a mixture of some are NCA wide, some are really local. If I'm honest, in terms of where to go first, we have chased money a little bit because we're still doing recruitment the old-fashioned ways while trying to put these processes in place. So particularly at the moment, there was a Kickstart gave us an income stream. We've had some money from the Princess Trust. So some of it is opportune. And then you always go with the willing because that's where the enthusiasm is. So I'd kind of say if you're using the equation of narrative plus data plus action equals change, there is always something going on in that space. And it's around learning from that and then thinking about how to scale it up.
I love that. I think that's such a helpful clarity, isn't it? And that, so that you talked about the sort of going where the energy is, and just reeling off there some of the partners, colleges, voluntary sector, faith organisations. Can you tell us a bit more about that collaboration and what, I don't know, maybe have there been any challenges to sort of that breadth of organisations involved in this? Particularly thinking about how do you get a big, maybe it's caricature, but a big bureaucratic organisation like a hospital trust working with a smaller community-based group. Any challenges there?
So as I sit here, as working from home, I've got a family picture up here. So I was raised in a ridiculously large Irish family, and my granny used to always say that the good Lord gave you 2 ears and 2 eyes and 1 mouth for a reason, because you should listen and observe twice as much as you should speak. And I think the NHS has really got to work and walk humbly in this space, because voluntary sector organisations, community groups, faith organisations, local authority, housing associations have been doing this for years, if not generations. And I think we need to recognise what we bring is size and scale, but what we don't necessarily bring is that connectivity to local communities, that some of those skills around community development, etc. So I would say that it is a true partnership when you work with. So let's take another organisation. So Positive Steps, which is a youth-based organisation that covers Oldham and Rochdale. They know young people. They know how young people tick. They know how to motivate, how to get them out of bed, and we've got jobs. So we literally, that was our relationship, was to say, these are the kind of vacancies that we've got. We had a fantastic youth worker, so Cynthia, who literally got people to practice getting on a bus because people hadn't done that, really understood their confidence and did work on that. And then we developed a talk-based program, and then we just put them into departments that fitted where they were and what their aspirations may be. It was quite individual. And then, those of us who work, in health, social care, or this sector, once you see the individual and you've made that connection, they kind of almost become part of that NCA family. And then it's no longer a program, it is just a human supporting a human, and that connectivity. So, we've got wonderful stories, but, the one that sticks to mind, we had 3 young people who ended up supporting the vaccination centre. And having been jabbed 3 times, I then saw them over the course of that period. And, first time they were really hesitant, they were behind the desk, they were, being led by other colleagues. The last time I went, I was in a queue, and I must confess I was doing like everybody else in the queue. I was writing my shopping list, mine was somewhere else. And I hadn't noticed there was an older gentleman towards the end of the queue on 2 sticks, and nobody else has noticed. A young woman who'd come from our programme spotted him and went and pulled him out of the queue, and quite rightly told everyone else who was in that queue, he's old enough to be my granddad, he should be first. And quite right, that's living by the values that we say we have as an organisation. And to see that young person's confidence develop, and they're running those vaccination centres now. And to say into into the admin and the coordination, and so to say, to go from being a NEAT, which apparently isn't about wearing your Sunday best, it's kids who are, that we have failed. And to see them actually be able to say, actually, what do you do during COVID? Well, actually, I was part of the vaccination effort, in a way that gave us levels of engagement that we wouldn't have got had we gone down a more traditional route. So I don't know if that helps.
It really helps. I think, well, that puts tingles down your spine, doesn't it? Because it's funny that hearing you talk about the 2 sides of this, aren't there? There's the kind of theory, the economic heft, we can make this work, like there's something that there's a big prize about poverty and getting at that 40%, but then the action is Cynthia and your people in the vaccination centre, isn't it? And that those relationships just shine through from what you're saying. I mean, it whenever I hear you talk, Donna, and hearing you this morning, it feels like there's sort of lights bulbs flashing all over the place. Do you feel like organisationally there have been any moments you look back and think, oh, that was really key, that was a bit of a breakthrough moment for us, that where this where maybe people who've been a bit more skeptical kind of really got it, or something changed in levels of engagement?
So I think because we were trying to operationalise this strategy during COVID, either by accident or by design, we're slightly meeting light. So we don't tend to have a structure that is very meeting structured. That doesn't mean there isn't a governance, because there is a clear accountability. But I think, so one way we bring people together is through community practice. So twice a year, we do an open invite, and it's a half-day session. The chair, chief exec are there, but also so are our community-based organisations. And how we run that is we start off with events in each of the localities, we develop the themes, and we bring it together. And that's how we use that to challenge ourselves. So the kind of people mission that I talked about, that all came from those conversations. And we kind of use that collective coming together as a way to both empower, challenge and steer us, rather than perhaps the more traditional NHS way, which is we set up a steering group and we have a series of meetings. Now, we do have meetings, I'm not saying, but I tend to do those more task and finish on a specific challenge. So one of the things that we came up with early is around when you are looking at recruitment, how do we then at the end of that programme move into a job offer? And so that was a task and finish group internal in terms of how do we make sure that staff side are happy, that we're not having some staff who are on short-term contracts. How do we manage those against a pre-employment learner? And so, you know, we've had to do quite a lot of backroom work, because the NHS uses something called the NHS track for jobs, and it's a really clunky system. So we've had to do quite a lot of manual workarounds on that. So I suppose that's so it's how do you, in really busy areas, how do you make time to take somebody who may need a little bit more nurturing to begin with? And I think that's just being aware of where different departments are and where different staff groups are, and just being purposeful about where you place people against capacity, etc. And particularly because we've got other responsibilities around training student nurses and doctors, etc. It's also saying, but actually, you know, our pipeline for our Band 2 healthcare support workers or admin or receptionists is as critical to the running of the organisation as it is around our nurses and doctors, because they can't exist without other colleagues. So it's kind of fitting it within a framework that was already in existence. So we are used to training students, so we've just created a new form of learners who are these pre-employment learners, but it's been mindful of where people are at in terms of what's been happening for the last 2 years. But if there was one thing I could recommend to colleagues who are starting on this journey, is community practice and the power of conversations. They have all been online, and it has been slightly technically challenging at times, but that's what it's those relationships that then what develop. And then underneath that, because I would describe it, it is like a social movement, but it's a social movement with a trajectory. So there are some hard numbers that we're trying to hit, and that fits into our accountability framework as an organisation. So I can break that down in terms of, you know, trajectories around pre-employment learners, or the NHS career ambassadors, or our procurement spend that we've equally got some milestones around. So it's, I'd say, social movement with trajectory, bringing people together, that and the power of a story. You know, story is data with soul. So we do a quarterly update that goes through our assurance processes as an organisation, and there's always a story in the heart of that report, because that, as you say, it brings it down to an individual level, as well as, you know, the millions of pounds that can be liberated if you do this differently. But when you can connect to a young person who'd been out of work for 2 years, who is now in employment, and how they can talk about that, or you can think about what, you know, when you look at it on a household level, what impact that can have.
I love that. A social movement with a trajectory. That it really resonates with, you know, I think somebody in Wigan said, you know, this is less command and control and more like, how does your garden grow? And I love that. There's something in this, isn't there, that, about the sort of top-down heft of an anchor institution, but knowing that this stuff, actually, you only bring about the change from people on the ground, really. And that, so how you get that balance, I love the community of practice idea, to bring both of those levels into play. So where next, Donna? Where are your sights for the next phase of this work?
So I think the next phase of work is still ongoing with employment, because we need to get to that 1,000. We're probably now clearer as to which type of pre-employment is we're getting better outputs from. So there's a bit of working on that. Procurement is a space that we're going into next. So we've had some as colleagues will have. So we've got capital build. I think we're much clearer about how do we get social value out of those capital builds. We've got so like Salford colleagues, the Salford Alliance, Social Value Alliance, which is led by the voluntary sector. I mean, that's had its 10% campaign, and we've been relaunched this week. But I think what we want to try and get to when we look at our procurement spend is, how do we use that to then generate economic growth within local businesses. So we're really fortunate that Chris Dabbs, who is the Chief Exec for Unlimited Potential, has just won a Health Foundation bid to actually look at, if you take our spend, the University of Salford spend, Salford City Council spend, how can we then use that to then develop an entrepreneurship, particularly with young people, around creating more social-led organisations to then meet that demand, because it's no good us saying we want to purchase stuff locally if it's not there to purchase. So how do we get what information we have about our spends out to then be able to kind of swing some of those local spend dials? but recognise within the NHS we don't have total control over our procurement because we have got national frameworks that we need to follow, etc. So I think that is a space that we're chipping away at and being clear where we can make influence, and being, purposeful is a word I like. So being purposeful in the procurement space where we can, what we can and can't do. I think the other area that we're really keen to look at is our estates. So obviously during COVID we haven't allowed visitors on site, so ability to use our estate for community use has been limited. And I think that is definitely an area when we think about our, all of our 4 hospitals, plus we've got some community services, have got ability to create 7 days a week cook food. How do we then use that as a community asset? Hospitals are part of communities, but actually, how do we make them feel like that? That area I'd like to go into. So if anyone in Wigan has done that, be really keen to hear from. I have visions of like having community gardens in all hospital sites, and I know different organisations have done that. So how do we do that? So I think there are areas.
Brilliant. And it sounds like that mixture of kind of keeping very clear mission and trajectory in mind, but then so where's the energy and the tactics? In procurement with the NHS, it's quite a tactical game, isn't it? Not where can we find the opportunity and really work it hard. Yeah. Brilliant. We'll look forward to hearing about how you get on with that. So before we wrap up, any last sort of words of wisdom for this gang as they set off on their day?
I think there will be stuff going on. There is in every large organisation, there'll be somebody who has taken on Princess Trust, or you'll have a supported internship programme, or you will have a capital build that's doing social value. So it is also about pulling out those individuals who are already doing that and celebrating what they've done. And kind of, I had a conversation with a colleague way back in 2019 who for years had always taken kind of a fire youth group that she just set up. And I remember having a conversation with her to say, but how come you've done it before it was trendy? And, just really saying, well, because that's my values, that's where I'm from. And it's taking those individuals and using those to really role model what can be done. So, no one's starting from zero here, but it's about how do you scale it up? How do you operationalize it? How do you stitch it into your everyday? So although I've got a fancy title, I've been Director of Social Value Creation, there is not a social value creation team, because I say I don't have a team because I've got 18,500 people and £1.2 billion spend. That is the team. And it's how do you mainstream this rather than see it perhaps that we may have done traditionally in the NHS, which is see it as a programme or a project. It's tasks that we all do all of the time, and how do you do it through that lens of poverty reduction and health and the wider determinants of health and health inequality.
Literally couldn't be a better message to send us off with. Thanks so much, Donna. And we'll keep the gang appraised of how you get on with all of that. Thanks so much for your time. Okay, thank you.